Go for it.
So first of all, my name is Jim, and I work for the company that actually manufactures the eye gels. You guys buy them through your local distributor, I believe. And you will get these replaced at Christ, and hopefully we're trying to get it set up so that eventually the other hospitals will carry this too as well, so that you guys don't have to, buy these out of your pocket. But so real quickly, has anybody ever used the eye gel before? Any other service? Okay. Has anybody? Well, let me go ahead and pass one around. And one thing I want you to kind of notice is feel the cuff itself. It's actually kind of tacky. But just a couple of things about it I want to point out. First of all, you guys currently use the King, correct? Mm-hmm. Okay, so and if I'm not mistaken, the King comes in a size 3, 4, and 5. Mm-hmm. Well, we come in a size 3, 4, and 5. So the first thing I would say is, because the first thing you have to decide is which size am I going to use on the patient, and we pretty much follow the same training method as King. So if you read our training material, it's going to say that we're based on weight. And if you look on the package, it'll say this is for your 90 kilogram and up patients. The problem is that what it doesn't say is its ideal body weight. So if you got someone 5'9", 170 pounds, they're a size 4, okay? But if they're 5'9", 275, if you look at that weight, you would say that they're a size 5, but that's not their ideal body weight. So that's just too much, BS going back and forth in the middle of a cardiac arrest. So here's the real down and dirty, simple way to remember this, and it's again similar to King. Your size 3 is kind of going to be for your 5 foot and under people, okay? Anybody 5'1" up to about 6 foot, you're going to use the size 4, the green. And then once you get to the 6'1" and up, you're going to use the size 5. So keep it strictly on the patient's height, because really that's what it's based on, and you won't go wrong. Now, someone's laying on the ground, how can you tell if they're 5'1" or 4'11"? Gosh, do I use a 3? Do I use a 4? The good news is you can use either one, okay? Same with someone that's tall, is that if they're 5'11", 6'2", you don't have time to really sit there and measure them, I can use either one of these things. My suggestion is when in doubt, if you're not sure if they're a 3 or a 4 or a 4 or a 5, just grab the longer one and you'll be fine, okay? The only time you're going to run into trouble is if you grab the 3 and they happen to be 6'2" or 6'3", okay? But you'll know immediately that you grabbed the wrong one, because if you notice on here, they all have this horizontal black line, and that's kind of your depth gauge. So when we go ahead and put this into the patient, and the good news is there's no cuff you have to worry about inflating, but at some point you're going to hit definitive resistance. I can't go any farther. And then if you turn around and pretend this is my patient's mouth, if you're sitting there looking at something like this where that black line is visible, you've got the right size. But if I put this one in someone at Tom's height, you're going to be looking at something like that. That black line is gone. And the problem is now I have no idea whether this is sitting over the trachea or not. Pretty good chance it won't be. You'll know, again, because you'll bag and you'll see no chest rise. But if that black line disappears, take it out and go ahead and put in a bigger one. Conversely, if I try to use this one on someone that's 4'11", it might work well. This might be right over the trachea, but if you look from the top to about right there where you can see there's that little curve, that's an integrated bite block built in there. Okay, so if they seize up or clamp down, they cannot close off the airway. But if I got this on a really short person, they will not be on that bite block. So I would recommend, if you can see this piece of plastic here at the bottom where the curve is sticking out, rip that out and go ahead and put in a smaller one. Okay, so that's the only 2 times you got to worry, but those are on the rare extreme end. So the cuff itself, as you notice, is kind of tacky. So one of the things we have to do, and you probably do it with the King as well, is we got to lubricate the tip just to slide it in nice and easily. They all have a gastric channel, so if they vomit or you want to decompress gas from the stomach, you can do that. There's a hole down here. It comes up here, and it just allows, if they vomit, again, fluid will come up that channel. It's kind of an oblong shape, and that's just to make it really difficult to kind of roll once it's inside the patient. So you don't have to worry about this thing rolling off the airway. And then lastly is this port right here. You guys probably won't use this. We sell these all over the world. And a lot of places, especially third world countries, only 2 people are showing up. And if they got to scoop and run, and all of a sudden now someone in the back needs to do chest compressions, how do you get them some oxygen? So if I pop that off, I can hook up an O2 line, and I can go ahead and get them some passive oxygen. Again, that's probably not part of your protocol. You won't do that. But what you need to know is if you see that cap off, that represents a leak in the system, so you got to make sure that cap is back on. Why would that come off? Someone might have thought this was the suction port. They figure out real quick when the catheter can't get through there, but you just want to make sure that cap is always on, okay? Any question? And again, you always see the number right up at the top there as well. Any questions on the 3, 4, and 5s? So the real, again, quickly, your 4-footers, your 5-footers, and your 6-footers in a nutshell, okay? Okay, so how do we use this? So the good news is, as I said, there is no cuff that you have to worry about inflating before you put it in, then deflating it and put it in, inflate it again. However, how do we secure this thing? So you have to use a head strap to secure this. And the only reason why you have to do that is because you're going to move the patient. Anesthesiologists use this all day long in surgery. They don't bother securing it because the patient's not moving. In your world, you're carrying them up and down the stairs, etc. So if you don't secure this, there is that chance, because again, you're going to be bagging and moving, that this is going to be moving around. You will pop that off the airway, and then I assume you guys hook up to entitled CO2. Mm-hmm. Yeah, and you'll know right away when you start looking at your waveform there. So we got to use the head strap. Probably the number one problem we have with this is people either don't use the head strap, or they say, I'm going to go back to using what I was using before. And the problem is, the reason this is the way it is, it looks like a cheap piece of foam. And I can tell you right now, if you guys wanted to try to rip this, I'm sure you could, but you would have to pull really hard. But it has elasticity. So if you do pop it off the airway, this thing will tend to pop it back on, okay? And the good news is they all come with the head strap inside, and they all have a packet of lubrication inside. So what we have to make sure, I already know that Christ does, but when more and more hospitals start stocking these for you, it's got to be this one. We call it the recess pack. That's for pre-hospital, and not the standard iGel, which is what they use in surgery, because you'll get no head strap, you'll get no lubrication, and you won't have these posts right here, which we use to secure it. All right, so if that happens, you just let me know, and we go talk to their materials management.
Have you been noticing a change yet in hospitals moving over?
Yeah. More and more of them have. So, and I've been working with some of the other ones here, and you guys are still, is this region 7? Mm-hmm. Yeah, so, and it's slowly, like Kankakee and all that area, they've all been switching over, but it's just kind of a slow process.
They're part of region 7, just further south.
Yeah,
region
right.
7, so
yeah.
make its way up here.
Okay, so how do we do this thing? When we do it, we take it out of the package. This will be packaged right underneath right here. So we just take this off. And then what you want to do is take it, set this down, and then go ahead. Oh, let me grab my lubrication. You want to go ahead and take your lubrication, open it up, and just go ahead and squirt that lubrication all over this little platform right here. This is going to give a real easy way for you to lubricate it. You don't have to put it in your glove, and now your hand's all sticky and everything. So you can pick this up now and put it in your hand. And then what we have to do is lubricate this kind of from side to side, this whole back side. So you're just going to start rubbing it along each. Go ahead and get the sides, get the tip. We don't want to get any over the airway, obviously, but just go ahead and get it. Mostly, this is the part that's going to rub against the mouth, and as long as it's lubricated, you shouldn't have any problems, okay? So for training purposes, and I recommend if you guys do any continuing education in the future with your airway mannequins, do not gunk it up with your spray and all that stuff. It just makes it, good old soapy water works perfect, okay? All right, so let me turn this around. So if you're doing this from, thank you, top of the head, if you want to just do a little lower jaw thrust, you do not have to put your hand in the mouth and hold the tongue. I also recommend if you do, put them in a sniffing position, that kind of opens that airway up really nice. And then instead of running it straight down, we recommend you just run it along the roof of the mouth. and it just follows it down, and you go all the way down until you can't go any farther. So why can't we go any farther? So the way this works, and this little airway device does a pretty good job of showing it. You can see there's the trachea, and up top there is the esophagus. When you pop this in and I hit resistance, now the cuff is sitting right over the trachea. The tip of it, if you look, you can see it's right inside the esophagus. And this is why I can't go any farther. This cuff is too big to go any farther. So when you feel that resistance, that's your indication to stop, okay? And as I mentioned, the first thing you want to do is just look to see where that black line is. And as you can see, that black line is, you can visibly see it. So I know it's good to go. I recommend your first couple times you put one in, just so you're comfortable. Before I go ahead and secure it with the head strap, just confirm that you've got a good placement. Because if you don't, then you got to take everything off. But just go ahead and do a couple of, see if you're getting a chest rise. If you are, boom, you're good to go. Okay, the head strap itself. Now, do you guys use seat collars very often anymore? Yeah. If you do put one on, it doesn't matter where you put the head strap. If you don't, you generally want to kind of, where your ball cap kind of rests on your head is the ideal spot. You can put it, at the top of the neck. I don't want to get it down low, because when you do this, and then you're coming up like this, just even pulling like this, I can feel a little pressure on my carotid arteries. And one of the reasons all the research shows this has better success rates than the King is because when they have the cuff, and when you blow that cuff up, you put pressure on the carotid. That does restrict the blood flow to and from the brain. Obviously not a good thing. You don't have that issue here. I'm not saying this will restrict the blood flow. I'm just saying it may. So to avoid it, just keep it up high. Okay? All right, so we're just going to go ahead, as I said, put around, and I'm just going to go ahead and hook up one side. And then the other side is where I'm going to tighten it up, and then boom, you're done. So I kind of talked through all that, but this literally is about a 5-second procedure. Okay? And then, yeah, obviously we'll just go ahead and you're going to start your bagging, and away you go. Okay, suctioning. Does the King allow you to, if they vomit or ever, suction through it?
I think there's a channel on it.
Yeah, some do and some don't. That's why I always ask. So the thing you always want to remember, what size suction catheters do you guys keep in your bags?
All of them.
Okay, good. Maybe later this year, certainly by next year, we're making this gastric channel larger to get a bigger catheter in. But right now it's a 12 French suction catheter. This one can get a 14 in, but just so you're not dealing with, should I use a 12 or 14, just grab a 12 and away you go. This slides easily in there, except this is curved down here. Now when you get to that curve, it's going to jam up. So what I recommend is, you've got some lubrication left on here, just go ahead and put a little bit of it on the tip of the catheter. And then this will allow you to go down as far as you want. And you'll feel it. You'll get to, I can feel, I'm in the bend right now. It's getting a little bit tight, but because of the lubrication.
Is there a different channel you're going in?
No, it's going, here, let me show you exactly where it's. So it's going right through this tip. And then because this tip is sitting in the esophagus, this is how it goes down, deeper into the esophagus. Okay? And so if you want to decompress gas, or however you want it, however far you guys normally would go, just as an FYI, and a lot depends, right? Someone's maybe got that, you can tell they got a ton of gas in their belly, and they just got done drinking, up 2 pints of beer. If they've got a lot of pressure, this could be a little geyser, so to speak. So what some places have done to preemptively strike that is they'll go ahead and preload the catheter, and they'll just, when they see it's at the tip, pull it back, then they just go ahead and insert it. Yeah, and then it's just sitting right there. That way, if they start vomiting, you'll still see fluid coming up the side, but now I just get my suction out, hook it up, and away you go. Okay?
Bill, did you hear that? Okay.
Have you guys thought about including that with the pre?
You know what? It's coming, but here's the thing. We've been trying to do that. The FDA says because you're putting a catheter in, it's a whole new product. You got to go through a whole new FDA approval process. We're in the process of doing it. We sell it in Europe like that, so hopefully that may be this year. If not, certainly by next year. But it's just FDA regulation. So, any questions on that?
So the actual depth is just in between that bite stick you're looking for?
But don't get too caught up on that. I can't go any farther. That's my
where you
depth.
stop? Okay.
Yeah. And again, because this is a nice soft tip, you are not doing any damage whatsoever. Conversely, if you resuscitate someone, one of the first things they tend to do is they want to reach for that tube in their throat. If they go ahead and rip this out, they'll do no damage to themselves. All right. For people who have surgery, who've had multiple surgeries, and they've had one of these, they know immediately the next day whether they had an ET tube or not, because this does not have anywhere near that same sore throatness that you had before. All right, so I want to quickly show, if I can see that one back. Thanks. So remember I said this guy's about a size 3 mannequin, but let's just say you're not quite sure, so you go ahead and put in a size 4. So I put it in. I'm going to go ahead and just to confirm before I can see the black line, but you can see I'm still getting a chest rise. So I'm not, don't worry. Like if you look at the black line, yeah, it's a little sticking out a little farther but it's still on the bite block. So there's no way I'm ripping this one out and getting a smaller one, because 1, I can see he's on the bite block. 2, I'm getting a chest rise. Good to go. Okay? So.